So without building up too many expectations, quite a lot of people have said that they've done outcome measures in their study and it didn't quite work, and their secondary outcome measures were better. And a few people have talked about outcome measures in their inpatient or outpatient service in the hope that that will provide some evidence for their management teams to get behind them and give them more money and more resources and more staff. Tim Nicholson, who's a reader in neuropsychiatry and an honorary consultant neuropsychiatrist at South London and Maudsley NHS Foundation Trust, hopefully will be able to help us with some of those questions. Thank you very much.
Thank you, Boyd. And there's a lesson in not turning up to a committee meeting when I got volunteered for this talk. I was surprised to be asked to talk about it because I like talking about it, but everyone thinks I bang on about it, and it's a fairly dry topic. But I actually think it is. I've become an outcome nerd, and I'm hopefully persuade you that it's interesting. But there are some very interesting aspects of FND, and I think it's really, really important to get this right. Just to say, I'm sort of off Twitter X now. Hopefully I can persuade most of you left on there to come to Blue Sky. Just a quick thing there. A brief outline of the talk. I can see bits of there's a warning from my university that it might shut me down at any minute. That's going to be slightly irritating, but it might be easier just to push on. I'll have to sort of stop the slideshow, I think, to get rid of that. Let's just see if I can manage it, but I don't think I will be able to. That's beyond my technical capability, sorry. So hopefully you can see everything still. So I'll be covering really basics of what outcomes and outcome measures are, about diving into the specific features of FND that make it a slightly different case to most other disorders. And there are lots of unique things about FND and functional disorders, and many of you will be quite aware of those, but I'll just go over those because I think it's quite important before we dive into what we should be measuring. I'll cover the best choices we've got currently, and then some future directions at the end. So let's get into the outcomes and outcome measures. So people tend to conflate outcomes and outcome measures, just talk about outcome measures and not forget which outcome should we be measuring first. So these are the features of the disorder, what we should be measuring before we then decide on how to measure it. Okay, so these are really quite simple things, but I think they get often overlooked. Actually, I will need to, unfortunately, I think, break out of this, won't I? Because it's blocking stuff at the bottom. So this is putting my cortisol through its paces. So let me just, sorry, the tech guys might, so hang on. If I drag this out the way and then restart, hopefully I can get rid of everything. And you can see a window into my brain, which is quite disconcerting, even for me. No! Okay, it's not better, but right. I will come back to cortisol later on. Because it is something you can measure in real time. And you can see the example of its impact right now. So, core outcome sets and core outcome measure sets are, again, the sort of outcome nerds area, but they're really important and people should know about them and try and develop them for all disorders. So this is really a consensus minimum set that everyone should collect to optimize comparison and collation of data. If you're not all measuring the same things, it becomes a bit pointless because you can't compare evidence and you can't compile it to get accumulating evidence. It's obvious. So what we should be measuring, there's various taxonomies of outcomes, and these are sort of fairly obvious in some levels, but again, it's hidden here as symptoms, and then you've got below symptoms, you've got physiology and biomarkers, and of course for the simple disorders, you might want to measure a biomarker that is purely, a complete description of the severity of that disorder, and that's what you're targeting with your therapy, and that's where you should be going. So down from symptoms into biology or physiology. But then above that, you've got the impact of symptoms on function, you've got quality of life, and then all things through down to things you might measure just in trials like adverse events, mortality, but you've also got health economics. And there's a few different classification systems of, this is really for the proper nerds, so if you want to get into this, it's very interesting. And I think FND and functional disorders have the ability to actually update our way that we do this. I think what we can understand will actually feed back and change this whole classification system, because I think we FND is this really central, or functional disorders, these central disorders, and which are of more relevance than we think. So once we've identified our outcome, it's like, what should we be measuring? And this is the agreed optimal way to measure, to develop a measure. So what are the features of a measurement tool that are ideal? And I won't go through all these because we've got a huge amount to whiz through, but there are all the obvious things about the responsiveness, its content validity, measurement error, all these standard things. And these are all, this paper here is very good, and the UK has led the way in this. Liverpool group are really, and some Dutch groups have really been leading the way in the sort of theory of outcome measures and outcome measurements. Just very briefly on these core outcome sets, which it can be, or core outcome measurement sets. So these are a minimum that everybody should be collecting and in a trial, for example. So trials is where it gets really important, but we want to do it everywhere, right? So it's not like you have to measure just that. It's that this is just the minimum set, and beyond that you can add in extra things that you might want to. But as long as you measure these other things, that's great. There's a consensus process, iterative process to define this, where you involve all key stakeholders, and critically patients and carers are involved in these processes. So the COMET group, based out of Liverpool, and the Evidence-Based Centre for Medicine in Oxford, and some Dutch groups have really sort of defined the methods for this, and there's a repository of all the outcome sets that have been developed, and it's an iterative process as we learn and develop more, we get more knowledge on what we should be measuring and how should we be measuring it. So it should be updated as a consensus process. So you should look for whichever disorders you want, and there's quite defined processes for arriving at these different things. And this is just me taking an extra level that you've got to not only you'll be measuring these different things, but it's a different, if you're a clinician or a researcher, and a researcher with a reasonable budget and a researcher at the place where you've got money's no object, you've got a sort of cone of different things you'll be measuring. So there might be something quite simple or one or two things, but at a clinical or a very sort of under-resourced setting for research. So there's a lot of things in the mandatory set that can expand, and so it could even be dynamic. It's not just a core fixed set. It could perhaps have it could sort of zoom in and out according to your resources and your interests as a clinician or researcher. And then there'd be optional extras you can add in that be recommended, and consensus on what those optional extras should be. So down to the sort of slightly more interesting bits about FND and what's different about it and how it affects choice. So there are these unique features of FND. So we know it can and does cause any combination of neurological symptoms, and so it can mimic any neurological presentation. So it's hugely diverse in its presentation. And we often increasingly find that the core symptoms that you're interested in as a clinician or referred for are not the ones that perhaps the patient is suffering with most. You're most in the seizures or the movement disorder, but it might well be that the pain, fatigue, other things are actually the key problems that are most disabling them. So this is where it's really important to sort of zoom out from our own specialist interests into what's going on for the whole person. So we have these diagnostic signs, and these are actually features of the disorder, and we don't know whether those are things we should be measuring. Is that going to disappear when you get somebody better, or things improve, or is there something that's just a state, and it's something that you wouldn't expect to improve? We don't know these things particularly well, and we know that symptoms rapidly change with attention, other factors. So the point you measure them at, whether it's subjective or objective. So objective strength in, say, with in functional weakness, limb paralysis, is going to change. The Hoover sign will make you get strength back. So at that point, you've got strength back to return transiently through a clinical manoeuvre. So that sort of shows us that actually objective measures, although they're important, it's exactly when you measure and how you measure them that becomes really critical. And it seems that and we've got, I'll show you, we've got some preliminary evidence to back it up, that it's really the subjective report of the patient that's going to be the critical thing rather than objective. And that's different to all other disorders where most funders and most experts will say, oh, the more objective it is, the better. But I think that is not necessarily the case for FND. And there's also unique applications. So this is just a really nice study from Mark Edwards and others, just showing another sort of feature. So actigraphy used to measure the actual frequency of tremors that are happening in some FND patients with functional tremors and those with organic tremors. And there's an overestimation between the so Parkinson's patients, I think they were mostly in this study, do overestimate the amount of time they're having a tremor, but with FND patients, it's a fairly extreme overestimation. So there's hardly ever a tremor, but as soon as it's checked in on, am I having a tremor? Yes, I am. So there's a huge difference there, and this is really important for what we measure. This is a nice survey that Matt Butler led at King's with others. Ollie Shishton-Sharman produced these lovely pictures showing about the wide variety of symptoms that patients with FND have. And actually, the most common symptoms are often the ones that we wouldn't even consider as core FND symptoms. So fatigue, for example, here. We didn't, unfortunately, ask about pain, but there's been a really lovely review by, as always, John and Alan and others clean up the mess of the literature and perform these nice systematic reviews for us, showing the amount of how common pain is in FND. And for most people, it's actually a core symptom that we don't measure as much as we should. What we've done in FND so far as a research group, when I was doing a trial of, which is still ongoing, the sort of, subsequent phases of a TMS trial for functional weakness, I sort of wondered what outcomes should I be measuring, and then realised there's been no work really on this. We're just borrowing outcome measures from other disorders and just sort of making it up as we go along. There'd been no thinking. So we put together a team of all the sort of experts that we could get globally to sort of think about this and come together and work on it. And we thought together about these theoretical and practical issues. And I think this nice diagram about the core FND features and then these other physical and other psychological features is probably quite a nice way of conceptualizing FND. And we really laid out these things in this paper, these key issues about the temporal variability in FND symptoms and the discrepancy between objective and subjective and how that's actually much more, the usual focus on objective is not necessarily optimal. So, a bit on the current best choices. So I think it's important, you've heard today from Glenn and Laura about their amazing work, and anyone who's done a trial of any size realises how much work's involved. But when you do these are the two biggest trials, and the UK has led the way, and it's not just, obviously John Mellors, Laura Goldstein and Mark Edwards and Glenn Nicholson who've done the physio trials, but there's huge teams, and the FND community in the UK has really pulled together to pull off these huge bits of work. But they're both negative for the primary outcome measure, but have showed huge benefits in many of the secondary outcome measures. It just shows the critical importance of getting the outcome measure choice right. And a lot of funders would have, slightly dictate what outcome measures should be your primary outcome measure. And there's not only what you should be measuring, but what time point as well. So once you've cooked your goose, you've got to say, I'm doing, whatever it is at 12 months. That's it. And if it's not negative, if it's negative, it's a negative trial, and you can't, so it's really, really critical to get this right. The next bit of work, this FND-COM group, the core outcome measures group that many people here in the room contributed to, but was led by Susanna Pick at King's, and as all the members here did a great review of all the outcome measures that have been used for FND in trials and all the specific FND outcome measures that have been developed. I won't go through all of them with you, but the slides will be available. So these are the outcomes specifically made for FND, including a really nice one that Glenn developed, so a simplified version of the functional movement disorder scale, sort of video-rated scale, which I think is very good. And then we also provided a sort of list of what other things have been measured in other trials to date. And finally, at the end, we had a sort of recommendations, consensus recommendations. We didn't go through the formal rigorous process of a COMET initiative because that requires quite a lot of work and time and money, which we didn't have. So we wanted to get something out quickly. And these are the recommendations that we have currently, which we should probably start to think about updating reasonably soon again. Other things just to mention for the psychiatrists, they might have seen this came out last summer. It was a long time in production. It's the Royal College of Psychiatrists outcome measures document. And within that, each of the faculties has their own recommendations. And the liaison and neuropsychiatry ones are relevant for people, but as are some of the others, so for example, intellectual disability, there's mentioning of seizures and epilepsy. So there's quite a lot of other areas of overlap between them all. So the liaison document covers functional symptoms. They don't explicitly, well, the PHQ-15, EQ, 5D, 5L is mentioned, but there are sort of very sensible, rational choices within that. And the neuropsychiatry recommendations are here, and again, thanks to all the many people who contributed to this chapter over the years. And so for FND, it's really, it's not a great scale, but the EQ5D is very useful. But the key advantage of this is that it's validated for calculating QALYs, so you can use it for health economic arguments to get funding. So that is actually one big benefit of it. It's simple, it covers pain as well, and it's got that sort of global scale. The only recommended change I would think about is that if you use it as published, it's what are your symptoms like today, or in the last 24 hours, but I think that should be broadened to at least a week, probably even 2 weeks for FND, because we have such variability. You're just going to get a lot of noise by the exact moment that you ask this question to people. So just also to say there's some qualitative study that Susanna led on with Sonia Rutten and a great patient researcher called Abby Bradley Westgard, and a huge qualitative study. For those, again, who've done qualitative studies, this is a massive study of over 60 individuals. It's just been published, and really looking at what these key different stakeholder groups think we should be measuring. It's quite hard to see here, but the bold bits in the table here are the things that everybody, the top 5 for each of the groups, and there is overlap but some differences, but as you perhaps expect for these different groups. But the take-home messages are that there are some critical domains, and they're the sort of obvious ones, but they're good. It's good to have that acknowledged and some data for that. And also subjective measures are at least as important as objective. So that's come out from this, which is, matches our suspicions sort of theoretically about this disorder. So how much time do I have, Boyd? -5, 3 to 5 minutes. Yeah, okay, great. So future directions, go through this quickly, a bit about current and ongoing work, some planned work, and some implications. And I think outcome measures for FND, I think, could be actually really relevant to the whole of medicine, and I'll explain why later. So, when it comes to the outcome measures, this subjective objective issue makes us sort of move away from thinking about just measuring, going down from symptoms to, muscle activity or some biomarker. But perhaps we should be thinking about range, so looking at just someone's global movement, just on a GPS, how much you manage to get about your house, whether you even get out of your house, go shopping. So these will be really good, I think, perhaps potential markers of recovery in FND. We could theoretically look at stress and autonomics, coming back to the stress responses. There are now some real-time cortisol measures that you can have in your skin that will measure cortisol from moment to moment, which is really a potentially interesting way, rather than just looking at heart rate variability and all the other sort of simple cardiovascular autonomic markers we've got. We can also think about measuring brain activity, and those of you who might have followed Selma Abach's work looking at resting state fMRI as a diagnostic tool, but you could equally longitudinally use it as potentially as a marker of recovery. And it's always slightly futuristic to think about brain activity being able to diagnose FND, but also could it stands to reason that there must be some sort of state change that happens that might theoretically be recordable through fMRI or other technologies. I think very briefly, just to go to naturalistic assessments, I think this is Franz Brunhuber, a neurophysiologist at KCH, who's a very good deep thinking neurophysiologist who's thought about the ecology of seizures, for a seizure variant, whether it's epilepsy or a functional seizure, it's the home setting and the natural environment that's important, and also the things that happen in and around a symptom or a person. So who comes to help, what happens. There's all these really fascinating things that happen as an extended part of observing and sort of rewinding and zooming out from us as humans to think of us as just animals, and these are complex things that happen to us. Just that there's a lot of technology in just analysing data just from noise patterns and bird songs. So you could almost think of the sort of patterns of noise and patterns of movement that might actually be detectable on a gross scale that could be informative. Remote monitoring is clearly massive for a lot of neurological conditions. We haven't really moved much into that space in psychiatry yet, but it stands to reason that functional disorders could really benefit, not just the physical symptoms, but also the autonomic arousal. Smart watches now can measure a huge amount, and there's some great work that's been published already, and some work. So Earl Anawatapong, who's doing some actigraphy in the latest version of our TMS trials, with Ivan Koichev helping out, and Susanna Pick's done some great stuff on ecological momentary assessment. So that's getting prompts on your phone or your watch to say how you're feeling at certain times of day, and done some great feasibility and pilot work that's just been published there. So very briefly at the end, implications for other disorders. So I'm just going to walk you through, I'm going to quickly say about a trial, an outcome measure we're trying to develop for FND. There was a call that was almost stimulated by the work we did with the FND-COM group, asking for an outcome measure for NIH, and together with Sonia Rutten in particular, but Alberto Espe in Cincinnati, John, Bridget from FND Hope, and many others internationally, we put together a big team and a big application that's in its third round of being beaten up by NIH reviewers. And today, as we speak, and in about half an hour, they're meeting to discuss our project. So if I look even more stressed later on, you'll know why. So finally, this is quite a. Have I got a couple of minutes, or should I wind up? Because this is quite a couple of minutes. Okay. So this is a proposal that I'm sort of road testing on you all, so please shoot it down, tell me it's all rubbish afterwards or now. But I think all symptoms necessarily have a functional component, and I'll just walk you, and I think this has a lot of implications. So this is based on the following propositions, that symptoms are the brain's constructed experience of the body, and its own function, not just the body. It monitors itself, our memory or other functions of the brain. So they're constructed from monitoring information, and it's compared to a normal range of healthy functions. So it's not just that it's monitored, it's how you compare it, how you distinguish it from healthy. And that obviously, illness beliefs, what you think is disordered or not clearly becomes important there. And functional symptoms arise at this level of symptom construction and deconstruction. So once it's come on, it also needs to be switched off. And that's how the sort of echoes of symptoms that start by one cause might remain through a functional mechanism locked in and stuck. And I think this sort of explains the seemingly universal presence of the placebo effect. So in any disorder, you'll get an instant response in symptoms that can only really be explained by the same mechanism as what's causing a functional symptom. And it also explains this huge explanatory gap between organic pathology and symptoms that's pretty much universal. And so there's an incredibly poor correlation, as most of you will know, between most physical disorders and the symptoms people experience. And this varies between individuals, and I think it varies over time as well. So I think it can start off as one thing, and that proportion, that functional component, can grow with time. And I think there's a functional transition that can occur once there's an insult or an injury, and the percentage of a functional component can grow. So, for example, here you've got an infection or an injury causing some symptoms from which you recover. And then you get chronic symptoms, so it might start off with some symptoms, then it might kick on into greater symptom load later on. And I think that the hatch lines here are for a functional component. So there's a proportion of your symptoms that, in the best case scenario, it doesn't rise to much, but it's still there. So if you applied placebo to that person on the left, you might get a 5-10% reduction in symptoms, but not much. But the case on the right, it might turn into a very large, and even the majority of the symptoms, or potentially all, if the underlying organic cause of the symptoms disappears. So you've got a sort of ratio of functional symptoms that you could potentially calculate. And I think most symptoms might even start with some organic seed of some sort. So we know that most functional disorders start with an injury, an infection, something. And it could even just be a brief physiological aberration that's actually healthy, but your brain focused on as the seed from which it grew. And we also know that through hypnosis you can induce symptoms, so it might even just be the idea of a symptom that's implanted externally. But I think this is important for symptoms, the whole of medicine, because if that makes sense to people and you can start to measure this, there must be so much noise in clinical trials resulting from this functional component that if you could somehow assess, measure, and either factor out that or potentially analyse separately patients for whom there's a large functional component, you'll massively increase the efficiency of your trials. So it's a sort of speculative thing to finish on, but I hope that's of interest and it stands up to some level of scrutiny. Thank you, Boyd.